I'm Dr. Craig Escudé, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it.
Welcome to this episode of IDD Health Matters. Our guest today is Dr. Deven Unadkat. Welcome, Deven.
Hey, thanks, Craig. Thanks for having me today.
So, Deven, I know what you do in this field, and it's incredible work. Tell us a little bit about who you are, what you do, and how you came into this world of healthcare for people with intellectual and developmental disabilities.
Well, that's cool. Thanks for having me here. So I'm an emergency physician and have been so for the past 19 years now. I can't believe I'm saying that, but
it goes fast.
It does go fast. And I can tell you about 10 years ago when I was working in an emergency department that was right next to a provider agency. It was actually an IRA in New Jersey that kept sending patients to our emergency department. Every day I'd see a patient with an intellectual or developmental disability brought in by a staff member, paid staff member, for relatively minor things. They'd be waiting around for hours on end for me to finish up with the strokes and the heart attacks, to take care of either a stubbed toe or missing prescription or maybe a fall without much injury. And within 5 or 6 minutes would kind of discharge them back home, fill out all the forms that are required. And after some time, I actually ran into one of the home supervisors and I started asking questions like, why do you keep coming to the ER? Why, isn't there a primary doctor that you can see or visit? And I started to learn about some of the challenges that these folks have when an acute change occurs. I mean, acute meaning could be a simple thing or it could be something a little bit more serious.
Right.
And the only source of medical care they really had was the emergency department. Immediate medical care that they had was in the emergency department. So that's why they kept coming to the EDs. And I was like, well, and I was talking to my future partners who also worked in that same emergency department, had the same concerns. I was like, well, if we could somehow intercept these folks at home and evaluate them there and then determine if they really needed to come to the ED for in-person care, I think that would be providing a higher level of care than what they currently have now. And you know what happens, right? They come to the ED, they wait around for hours on end, they miss their medications, they're hyperstimulated, they're in environments that they're not used to, people that they're not used to touching them are touching them. And our patients really have this heightened awareness, this heightened sensitivity to these types of things. And it's traumatic, to say the least, for these folks.
Yeah, you talk about the trauma to the person. It can be difficult for the organization who's providing support as well, too, right? Because the staff has to go with that person. Oftentimes, there's transportation involved. There are other people that staff member might be working with, and then we have to find someone else to come in and do that as well, too, or provide the supports there. And it might be, like you said, just for a prescription refill or something relatively minor that could easily be handled by what solution?
By our telehealth solution. So basically, what we did was we partnered with 2 provider agencies to provide telemedicine before telemedicine was in vogue. So prior to the pandemic, about 8 years ago, we got a small grant to kind of prove the concept of whether or not, and even actually prove it to ourselves, whether or not something like this where we can zoom in. At that point, there was no such thing as Zoom, but actually video teleconference in, have access to their electronic medical records and make high quality medical decisions to try to prevent these folks from having to go to an emergency department and then spend time doing the things that they enjoy doing rather than coming to the ED. They can go to their day programs, they can go to jobs and actually live a meaningful and independent life, and not be stuck.
Who wants to spend time going to the emergency department? I mean, no one does.
No one does. Yeah. Even me, who lives in the emergency department, doesn't want.
Yeah, you get paid to be there, right?
I don't want to be there. Right. So again, a lot of the push was to kind of level the playing field for the folks with intellectual and developmental disabilities. You and I have a telehealth option. You can just pull out your insurance card right on the back. There's a telehealth option for you and I. But folks that are on a Medicaid waiver that are adults with disabilities don't have that same option. And we kind of set out.
They didn't, but they do now.
They do now.
Right.
Exactly. And that's where we are. So we started small. in New York with 2 ICFs, actually. We felt
intermediate care facilities.
Intermediate care facilities. And I thought that would be the best place to start because they had more support. And we showed a 90% treat in place rate.
Okay, wait. Say that again and explain what that means.
Okay. So 90% of our patients that we got called to see when there was an acute medical issue, we were able to manage successfully at home without having them leave the home and go to the emergency department.
So for an agency out there who has people that frequently go to an emergency department, what you're saying is that about 90% of the time you could prevent that person from having to go to the emergency department. I just want to make that really clear, because that's incredible. I mean, that's incredible.
And that statistic has been consistent. That's the one thing that has been consistent throughout our history as an organization. Anywhere between 89 and 94% of our calls stay treated in place, which means 90% of the individuals that work with us have a better quality of life, higher access to quality health care by trained physicians that know the IDD space, and provider agencies save lots of dollars on overtime costs, transportation costs, and also state Medicaid programs save a lot on hospital readmissions, hospital ED visits, and even urgent care visits, which are much more expensive than a telehealth visit.
Well, that makes perfect sense on all fronts.
We think so.
But yet I bet there's still some challenges to people adopting this. What are some of the challenges that agencies or states might have, or that you have as an agency in getting this adopted?
Yeah, so a lot of, everybody feels that this is the solution. This is one of the biggest solutions out there that really impacts all of the different areas that we talked about: the provider agency, MCOs and health insurance plans, states and programs, and health equity issues. But a lot of this is, how do we pay for this? How does a provider agency have the funds that are working on really small margins put in the money? How do states lobby for more Medicaid dollars to help pay for these types of services? Because a straight fee-for-service model for a service like ours, that's available 24/7, every holiday, every weekend, 3 a.m, Saturday night, when something happens, I need to have staff available. Sure. So I need to be paying those staff in order for me to keep the lights on. It's got to be more than a Medicaid fee-for-service type of schedule. So one of our biggest barriers or challenges is actually, where is this money coming from? But with that said, I mean, we have 40,000 individuals in 20 different states that we currently have. Like I said, we started small with 2 ICFs, about 30 people. Yeah. And now we've grown significantly, and people find ways to make it happen,
And when you look at the data and the cost savings, you've got some significant data in terms of even on, I know some residential programs will save thousands and thousands of dollars using your services. And that's just the cost to maybe the residential program itself, not even including the cost of the healthcare world.
Exactly.
Right?
It's not total cost of care. Yeah. We're just talking about the cost of overtime dollars for staff. That's literally, and if they're responsible for transportation, if they have the vehicle and transportation. So it's really, we're talking like $80,000, $90,000 annually for these small group home facilities that they end up saving, that they can use to kind of support DSP costs, other costs, So we know that there's a challenge with support staff in these homes and retention. Well, if you have an extra $80,000 to spend, why not throw it back into the DSP pool?
And that makes perfect sense, and that shows the case that this is doable for even smaller agencies. Yeah. So how about the thought, or what's your thought on people saying, well, are you going to come in and be the primary care doctor for these people, or how does it work? How does it look?
So that's another perceived challenge. Initially, we thought we'd be really a bigger challenge than it actually is now. We make it perfectly clear that we are not the patient's primary care doctor. This is not a substitute for a current medical service that they have at the moment. This is an additional medical service. So it should never be that telehealth is going to take over a primary care physician's role. That PMD, or the primary care physician or provider, is integral to the health of this individual and the success of this individual's life. We are there to help bridge the gap. Because, come on, let's be serious. You're a primary care physician, Craig. The way that the system works, you're seeing patients every 10, 15 minutes. you just don't have the time to stop seeing patients and address an acute care issue. Your job is to see your patients every 10, 15 minutes. What we have done was kind of just build an extra layer in there of support for the primary care doc, for the provider agency, where our docs are on, waiting for these calls to happen. And then we loop in the primary care physicians so they know what occurs. And we always encourage our patients to follow up. Yeah, sometimes it's not immediately, because sometimes you don't need immediate follow-up, but the next time you go see your primary for a scheduled visit, make sure you take our documentation with you so that at least they're in the loop. They know that you missed a med here and there. They know that, you fell once or twice. And, that can, for the long-term play of this individual, make a difference.
Now, speaking of documentation, do the provider agencies and sometimes the clinicians that you work with have access to documentation of those visits?
They every single one of them do. And we encourage that, because our provider agencies certainly need documentation of an encounter. So they have access to our patient portal. And that's something unique that we've actually designed specifically for the IDD space. Again, remember, all of our patients are IDD. All we do is focus on individuals with intellectual or developmental disabilities. But along with that is that the support staff, when you have access to your patient portal, you have access to your own patient portal. Right. Our patients need access. Yes, they themselves need access, but also their nurse, their care coordinator, their home supervisor, their DSP also needs access to that note, because they need to know what to do for this particular person. And standard patient portals are not designed to give access to multiple people that are caring for this one person access to that record. We've designed ours that way. So this way, the second I see somebody, notifications go out to multiple folks, their emails or text messages that say, hey, one of your patients have been seen by Station MD. There's a link to log in. It's a secure HIPAA compliant portal where you can now see exactly what happened with this individual.
That's invaluable, really, an invaluable part of the service. So what happens if you see a person on a telehealth visit and then you determine that, yes, they do need to go to the emergency department? What kind of communication happens, and how does that work?
Yeah, so like I said, we're in 20 different states, 40,000 patients that we take care of. Obviously, we're not on staff at every hospital in all those states. But what we do is we facilitate the communication between what we're finding on our side and our concern and the emergency physician that's going to see them wherever they are locally. So we'll ask, hey, where does this person's what hospital they normally go to? Oh, they go to University Hospital in this town. Wonderful. We'll get that town's information. We'll say, hey, DSP, it's time to activate your emergency response. Call 911, get this patient over to the ED. Tell them to take them to X, Y, and Z emergency department. I will call doctor to doctor, have a conversation with that emergency physician, and give them key important facts on what is going on with this individual firsthand, so they know what to expect. They also know to expect an individual that has special needs, to make some special accommodations for this person. And we see that really successfully occur throughout the country in all the different states that we're in. Because as an ER doc, I know when I don't have information, it's very anxiety provoking for me. Sure. And what ends up happening is I do the shotgun approach, do everything. I'm going to find something. And I don't know, nobody out there in the community has communicated with me. I don't know how to reach a doctor in the community. I'm just going to admit this patient. And this is where the snowball effect occurs. And we're hoping that this level of communication, actually we know, this level of communication gives that comfort level to that ER doc, so that if there is some more questions, they can call us. We have access to the records. We can facilitate that. But also, if they want to discharge somebody, they have that comfort level that, Station MD is there.
Back, you're there.
Yeah, we're there.
You're there, and you'll help support the person from a medical standpoint when they come back to their provider agency, because that provider agency can still call you and reach out, and you can do follow-up calls and all kinds of different things like that. Yeah.
Yeah. If I'm sending somebody to the ED because they hit their head and they're on a blood thinner, that's what I'm communicating to the ER doc. Hey, they're on Eliquis, they hit their head. All I really am worried about is intracranial hemorrhage. We know the patient's creatinine's mildly elevated. We also know they have a UTI. We're treating them for that UTI at home. Don't worry about all that stuff. We've got that under control. Unfortunately, he hit his head, so we need to really make sure there's no bleeding. That piece of information is so critical, because if I didn't know that as an ER doc taking care of somebody that I've never seen before, somebody with a UTI, developmental disability, and chronic renal insufficiency, on a blood thinner is getting admitted to the hospital. You know that.
I certainly do know that. So, talking about, you mentioned that all your docs are trained, and I'm well aware of what training you use, which is a great partnership between our organizations, which is Station MD. I don't know if we said the name earlier, right?
I hope we did.
I hope we did, but we certainly have to say it again. So Station MD and Intellectability work together to provide training. We provide training to your clinicians, and then the amount of experience that you have in this field on top of that really sets you apart as a provider of telehealth services with experience and training. And that's really invaluable, I think, and it really speaks to health equity. It's providing specialized healthcare, providing a level of healthcare to people or clinicians there who have an understanding of that person's particular healthcare needs, so that they can have a good healthcare experience and a good healthcare visit and get their needs met in the best way. Yeah. Great model. There's no doubt about that, for sure. So Station MD is the company. Deven, what do you do at Station MD? What's your role there?
Well, so I'm one of the founders of the organization. Myself and two of my other emergency medicine partners actually founded Station MD, and I serve as the chief medical officer for the organization.
Very good. And if people want to learn more about your services, get information on how they might access your services, where do they go?
Yep, they can certainly go to our website, stationmd.com. It's stationmd, one word, .com. And you'll see all of our offerings, all of our service lines that we offer. Again, we're a telehealth organization on 24/7 to take care of any acute issue that is focused only on individuals with intellectual and developmental disabilities. So all of our patients have some level of an intellectual or developmental disability.
All right. So there's one last piece, one little thing I do here. I call it 3 and 3. So I'm going to ask you in 3 minutes to give us 3 words of wisdom, 3 lessons learned, 3 pieces of advice that you think people out there could benefit from, or that they could use to help foster health equity and health and wellness for people with intellectual and developmental disabilities.
Okay, that's an interesting. I've never been asked this. So 3 words, three concepts,
3 thoughts, 3 concepts.
Okay, yeah. I think persistence, advocacy, and education. So I think being persistent with an idea that's innovative and creative, that's going to involve multiple different layers of the system that already exists. Again, takes persistence. You have a great idea, it just doesn't happen. You have to really focus on it and keep pushing and pushing and pushing. Education is key. So I think educating medical providers on intellectual and developmental disabilities and advocating for our patients at all different levels, whether it's advocating with their primaries, with their specialists, or advocating at the state level for services to make sure that our patients receive the same level of care as every other person in the United States. I personally believe that healthcare is something that everybody deserves, high quality healthcare, something that everybody deserves, and individuals with intellectual and developmental disabilities are no different.
Perfect. Deven, thanks so much for joining us again. The company is Station MD, stationmd.com.